And I'm going to talk to you guys about renal recovery. So, when John and I started working on biomarkers some 5-6 years ago, we actually were speaking with a bunch of different companies and collaborators, and John said, we should really start with recovery. That's where the action is. And we ended up working on early diagnostics, and we've had some very nice markers that work, but it never left us the fact that this recovery issue is really important. And I'm going to take you through where we are with renal recovery, why it's so important, and what we need to be doing moving forward. So if you look in the literature, particularly literature that's before 1995, this is sort of the definition of renal recovery. Are you off dialysis? And this notion of it being a binary event, am I on dialysis or off dialysis, is that what renal recovery is certainly informative. It's certainly important to the patient, but really we know that there's more going on than that. The ADKI definition that was actually presented very early on was this notion of recovery within 50% of baseline serum creatinine. And this seems quite reasonable, but this really has not been fully validated. And we've been using this to a significant degree because it seems very reasonable, and I'll show you the data about what we think this cutoff should or shouldn't be. And if you look at the clinical epidemiology that's available, and there is an enormous amount, I'll show you some of this, it looks like that when you get to within 15 to 20, 25% of your baseline serum creatinine, your long-term mortality hazard normalizes back to your baseline. And in other parts of the literature, you'll see things just something saying if your serum creatinine is less than 2, completely independent of whether you have CKD in advance or not. And obviously this definition isn't that thoughtful. And if you have a child who has suffered an episode of acute kidney injury, almost all of them will be within 50% of their baseline, but if they have new hypertension or proteinuria, have they fully recovered? And the answer is clearly not. And you'll see some data that'll be published in the coming months where looking at trauma patients from Iraq and from Afghanistan who had acute kidney injury, they recover similar to children insofar as many more than get back to baseline. But they do have evidence of chronic kidney disease in the form of new hypertension and proteinuria. And because they're military recruits, we have their baseline data and baseline values, and so we know this. And so this issue is really important because I think it can't be the same recovery definition necessarily for all populations, because for children and young adults, proteinuria and hypertension are significant considerations. So Nish Panu, looking at a large set in Alberta, basically looked at patients who've had acute kidney injury and then looked to see if they recovered. And what you're looking at is the composite endpoint of risk of death, ESRD, and sustained doubling of serum creatinine. And what you can see is that when you break across the 25% threshold, so what this means is that you have acute kidney injury, you begin to recover. If you get back to within 25% of your baseline serum creatinine or EGFR, the death hazard is no longer statistically significant. You basically continue to cross 1. Although the point estimate is still a little bit to the right. But once you break that 25% threshold, right, now you see very clearly that the risk for this very important composite endpoint is statistically significant. And it's almost prescient, when you break 50%, the hazard massively increases. Right? So the ADKI, where they presented this, I think it was 12 years ago, John? This is sort of dialing it in from a pretty long time ago that this 50% threshold ends up being really quite important. So what this means is that this is only one large data set, and I'm sure others will follow looking at this, but you have to recover pretty close to your baseline in order to remove the hazard. Now, we don't exactly know what's driving these outcomes, but we certainly suspect that CKD and other things related to that are critically important. And remember, recovery means different things to different people. There's long-term recovery, which is enormously important. But there's also sort of short-term recovery, right? So their creatinine is going up, and it begins to plateau, and clinically we have a decision to make. Are we going to dialyze them? Are we going to wait? Do we start really doing more invasive hemodynamic monitoring because we really don't know what's going on? If you knew they were going to recover in the next 48 hours based on a functional test or a biomarker, you'd likely back off. If you had a similar test or functional biomarker that told you with a high degree of certainty that this person is going to get much, much worse, you'd probably dispense with all the fluid challenges and put them on RRT. So there's short-term considerations. There's medium-term considerations in the next 3 to 14 days. They're sort of in between. They're not necessarily, at the point where I have to intervene with renal replacement therapy, but their creatinine's nowhere near normal. What should I do? And certainly we have long-term outcomes. And we're going to need to be able to clearly quantify what we think is valuable in each of these domains. And it's not necessarily limited to these three, but I just chose these three to put them into some sort of context. So if you look at these injury patterns, Etienne Macedo did this really beautiful study looking at patients who were seen by nephrology consultants and looked at the patterns. And it's not an enormous analysis, but I think it's highly instructive. So it's around 84 patients. And what you see here, this is the group that recovered their eGFR back to above a high level. And what you see is that they have their acute embarrassment, but at 3 months, and this is technically the threshold between acute kidney injury and chronic kidney disease, you can see that they're actually still recovering, right? You continue to see this going up, this improvement. So at this point in time, if you assess them and look at their baseline serum creatinine or eGFR, and then look at their eGFR for 3 months, you would conclude that this person has sustained a permanent loss of renal function and has CKD. But you can see many of them continue to improve. And some of them actually appear to go above what appears to be their reference creatinine. So maybe the reference creatinine wasn't important, but it also could just be loss of muscle mass, which John Prowell has shown, that gives you an artificially elevated eGFR. And if you look at this other group as well, this is the group that sort of gets a medium recovery. You see the exact same phenomenon, although it's less pronounced. And so is this acute kidney injury, or is this CKD, or is this AKI taking longer to get better? And I don't think we have a very good answer for this. But if you look at all the data looking at outcomes, we know that if your serum creatinine is significantly lower than where you started and you have some element of CKD, it's associated with worse outcomes. Clearly trying to return back to your baseline is important, but not everyone does it in 3 months. I think that all of us have a few handful of cases of patients we've taken care of who've done this. When we start looking at this pattern is quite consistent. For other patients who are destined not to recover, the 3-month time point ends up being quite informative. And this is in the same cohort, but these are the patients who didn't recover. You can see that they go down, they have their acute episode. There's some improvement, but they essentially plateau all the way through. And so, being able to put definitions so that we can predict these outcomes to allow us to make thoughtful clinical decisions is one of the challenges we're going to have to manage moving forward. So this is a paper that a group of us wrote about renal recovery, and really what we're talking about here is, at what point do we say you're recovered, and what are the thresholds that we need to say you've done well or done poorly, or we need to intervene? There's being off renal replacement therapy when you leave the ICU. There's being off renal replacement therapy in 90 days, and there's whether you return to your baseline serum creatinine, and do you develop CKD, all of which are critically important. But I think the other thing to recognize is that these shorter-term endpoints of decision-making are much more applicable to what we have in the hospital. And this is a paper that John Kellum and Kiyoshi Kishani wrote. And what they did is they looked at the ADHI-10 proposal, and just to remind everyone, there's this top left in the 2x2 factorial place where you have essentially normal indices of function and your biomarker negative. This is essentially a kidney which is doing reasonably well. You have the group in which you have a functional loss, but you don't have damage markers being elevated. This could potentially be pre-renal, a term I don't really care for, but maybe just pure functional. And then you have the group that is essentially damage positive, meaning their biomarkers are elevated without significant functional loss. And then you have both, and this has been nicely demonstrated that you have much more severe outcomes in this group. But it actually goes both ways, and what they propose is this notion that if you already are in trouble and have acute kidney injury, and you're at the point where you have a recovery biomarker and you have improvement in functional status, you're obviously well on your way. There's also a group of patients who their biomarker recovery, or the markers, are not elevated, but you begin to see functional recovery. Is this a person who just has CKD or a loss of nephrons that they're not going to recover? And then you have someone who potentially does not have functional improvement, but they have evidence of biomarker improvement, and this makes someone who has impending improvement. So this is the ADHI-10 model, but in the opposite direction. And then obviously you have the most significant group, which is that they don't have any evidence of a recovery biomarker and they have no functional improvement. And if you think about where we were with rifle, right? Rifle going to akin to KDIGO took 12 years. I refer to this, as I said yesterday, as 12 years a slave to get a definition set. So it is my sincere hope that when we work on recovery, it doesn't take 12 years. Because if it does, we have failed as a community miserably. It ought not to take that long to get this done. And it's critically important because in order to set benchmarks, in order to actually put these ideas, these biomarkers, these functional tests to the test, in order to assess them thoughtfully, we have to have consensus definitions. So if you begin to look at the available data on what the biomarkers are that appear to be useful, it's actually quite interesting. So this is a paper that John Kelm's group did in the ATN group with the biomarker study, and what they demonstrated is pro-inflammatory biomarkers were associated with less renal recovery, similar with apoptosis markers, and that's rational and that makes sense. But these are over the longer term, right? And then if you look at patients for urinary biomarkers, what you find in this reasonably large set looking at high-quality markers for patients who recovered, what you find is that you can use all sorts of different biomarkers, whether it's IL-18, NGAL, urine output, and you have decent performance but not great. If you then add in a pure clinical model, which is using age, comorbidities, Apache 2 score, you can drive up the ROC curve value to around 0.75, which is good, but it's really not what we want. We want to perform at a higher level. And not surprisingly, if you then take biomarkers, and some of them are the usual suspects, and here it's urinary cystatin C, urinary NGAL, you begin to start seeing the typical performance we see on the opposite side, which is the diagnosis of AKI early on. These markers also appear, and this actually lends much more credence to their biologic place in renal injury and recovery. And then you get better performance, although these are combined models. And then if you add them all together, which is a clinical model, and you add a clinical model to biomarkers, you end up starting to get performance which is really quite robust. Now, this is a small cohort, but I think this is a nice demonstration of where we need to be headed. We need to use clinical data along with biomarker data, and I think functional assays, and I think if you put all three together, you'll begin to have much better performance. And I'd like to make a point about this notion about which test is better. I don't think when you spend time with cardiologists, you hear a lot of debate about, that treadmill stress test is so much better than the dobutamine stress test. And we're going to do a 10,000-person head-to-head trial of dobutamine stress testing versus treadmill stress testing. They don't do it because they recognize that these are tools in their toolbox. And they use their biomarkers, they use their imaging, and they use functional testing as a portfolio to interrogate the heart and to interrogate the disease. There should be no difference in what we're doing for acute kidney injury and in CKD. So I would like, as a community, for us to move away from this A versus B versus C versus D. This represents a set of tools in a toolbox, and I think what we need to do is quit doing all the studies that are nauseating for the comparisons over and over again, but rather start being able to get clinical practice guidelines on how you put these together to help deploy them at the bedside so we can make better decisions for our patients. So I think another thing that Noel mentioned, but I think is really important, Mike Hung showed this, that fluid overload remains important. The pediatric nephrologists have been a decade ahead of us in this insight, but not surprisingly, fluid overload is important, and he demonstrated that this is important in about a set of around 200 patients looking at what predicts recovery within a year, and they demonstrated that for each 1% fluid overload, it was important to outcome. The reason why I mention this is that as you go out there yourselves doing these large clinical studies, try and ascertain the fluid overload data if it's available. I think it will add value to the models and to the prediction. And lastly, there's been some very interesting data about furosemide stress testing in acute kidney injury. And so Peter Vanderhoort and Peter Pickers and their group actually did a randomized controlled trial testing the use of furosemide to improve, to treat or hasten the recovery of acute kidney injury. So these are all patients who were CRRT. They gave them furosemide, and this was the result. So furosemide and loop diuretics in general in no way, shape, or form treat AKI, nor do they durably hasten recovery. Period. This data isn't, there's new data for this and there's old data for this. But what furosemide does do is on the acute side, it is highly informative. Patients who respond to furosemide tend to do better. And we published our furosemide stress test paper in Critical Care. They replied back with a letter from this RCT, and what they demonstrated is that in the group of patients in whom got furosemide, so this is now the intervention group of the study I just showed you, they demonstrated that furosemide revealed the patients who were destined to get better. And with a very solid ROC curve value of around 0.8, 0.79, that was highly statistically significant. And so what this basically means is that there is a place for biomarker testing and functional testing to help inform us on what to do with our patients. And similarly, in our furosemide stress test study, while it was true that furosemide stress test outperformed other biomarkers, furosemide stress test did the best in the cohort of patients who had an elevated NGAL or an elevated nephrocheck. And we know this in cardiology that you don't stress test patients who don't have angina, chest pain, or a positive troponin. It's not informative. But for those patients who have a little bit of elevation or a little bit of question and you really have some uncertainty, functional testing is very good at revealing it. When you perturb a system, a physiologic system, you force it to reveal itself. I think that's why we need to think about combinations of biomarkers and functional testing. So we've discussed this notion of major adverse kidney events, also adding cardiovascular events. This needs to be a part of the assessment. But for the short-term recovery question, and this is data that John Kellum was very kind enough to share with me looking at their Hydenic data set, and basically I don't want you to look at all the p-values and the mortality. What I want to show you is these notions, which is that the window for recovery. So what's an important and informative piece of information to you? So what this basically means, the 24 by 48, is that that's the time window for the recovery. So within 24 hours, they're going to get better. And the 48 is for at least how long. And what that means is returning your creatinine back to within 50% of baseline. So is that the most informative thing at the bedside? So I gave you a biomarker, and I said, this biomarker has gone from A to B in concentration. And that will tell you that in the next 24 hours, this patient's creatinine and urine output will begin to improve for a sustained period. Would it be 24 by 48? Would you want to know that it's going to happen within 48 hours and at least last 48 hours? And there's all sorts of combinations of it, 72 by 48, 24 by 72, 48 by 72, or 3 days for 3 days. And the answer is we don't know yet. And we don't know clinically what's the most informative. But I do think that if I could tell you that someone has acute kidney injury, they're not yet on dialysis, and we've done a biomarker assessment, and within 24 to 48 hours, they're going to have a sustained recovery for at least 2 or 3 days, that would be enormous value in your clinical practice. It would change what you would do next and would allow you to make changes for the better. As to which window is the most informative, we don't know. And I think one of the things that as a community we need to work on for the next 6 to 9 months is to start proposing renal recovery definitions and guidelines that we can all work towards and agree to so we can continue the study of acute kidney injury on the side of recovery to continue to try and improve outcomes. I think what's also very important is that the recovery biomarkers that we discover and the functional markers are likely also informative to tell us about long-term outcomes related to chronic kidney disease and major adverse cardiovascular events, and may help us intervene in those patients in a post-injury prophylaxis fashion. So, in summary, urine and plasma biomarkers have the potential to assess and predict renal recovery. I think fluid overload remains an important covariate. Please keep this in mind for those of you who are looking at the literature and also doing clinical epidemiology studies and thoughtful prospective studies. Functional testing, in my view, clearly has a role. It is complementary. And I can say this because we're the ones who developed the furosemide stress test and standardize it. But, you know, there was no special genius, right? I mean, people have been doing furosemide stress tests for 50 years. We didn't magically develop this. We didn't divine this from the heavens. We just took 50 years of clinical bedside knowledge and we standardized it. So we need to take that information and add it to the biomarkers to get a more robust and complete picture of our patients. And I think that, as I mentioned previously, and I'll say it one last time, getting consensus agreements together for renal recovery in a timely fashion is critically important.